Whenever you're ready.
Good morning. Welcome to heart.org. This morning, our topic of discussion will be on atrial fibrillation. And we have Dr. Douglas Packer with us and also Dr. Sam Asirvatham. And as we all know that atrial fibrillation is an epidemic, and at least in America and around the world as well. And we will start with a brief discussion of the overall practice in atrial fibrillation today, and then we will get to the specific topics of ablative therapy for atrial fibrillation, then of course the big topic on stroke prevention. So I will start out with a conversation asking Dr. Packer about the atrial fibrillation today that in our practice at the Mayo Clinic, and where we are and where we have been and where we're going.
It's an enormous problem, Win. I'll start with that because the issues really begin before these patients even get to you and I. If you look in the United States right now, there are about 2.5 million patients that have atrial fibrillation, maybe 200,000 new cases each year. And we have individuals out there who have atrial fibrillation and risk factors who are at stroke risk, and at the end of the day, they don't even know that they have it. So where we've been is in a situation where patients don't know. So the first step in all of this has to be public awareness programs. There are a variety of those going on. Heart Rhythm Society is doing one of those, but that's to identify kind of a know your pulse. Can you feel the fish flopping in your chest to even get the patients in to see a physician? I think that that's critical. And then after that, we look at things like risk factors. What are they? Do they have hypertension? Do they have diabetes? Have they had a prior stroke or TIA, kind of a near miss phenomena? Have they got ventricular enlargement? Have they had a myocardial infarction or heart failure? And so these patients are in a different group. Mm-hmm. And so we start with identifying where the risk is so that we can deal first with the anticoagulation question.
Excellent. Excellent. Yes. I turn the question to Sam today that with stroke prevention, we know that traditionally we have warfarin, and now there is really an explosion of new pharmacological therapy for stroke and in patients with atrial fibrillation. And then there is also a really very exciting area for non-pharmacological therapy for stroke prevention. Could you give us an overview, Sam, about for stroke prevention for patients with atrial fibrillation?
Yes, so I think for stroke and atrial fibrillation, it's important patients know three things. First is atrial fibrillation, no one dies just because of too rapid a heartbeat. The real risk we're worried about is stroke. The second is just for patients to be aware that the stroke risk and Afib, it's a complicated relationship. It's not always the Afib that produces the stroke, but more the company that it keeps. These risk factors of hypertension, diabetes, and structural heart disease. But in patients who have Afib and these risk factors, today compared to even 5 years ago, there are choices for trying to limit the stroke risk. One is traditional warfarin use, where probably we have the best understanding of who should get warfarin and who it's okay to be with aspirin or even nothing else. But of the choices that are available, once the decision that stroke prevention is needed is made, then the choices today is mainly dabigatran or a non-pharmacological approach. Advantages of dabigatran over warfarin is same dose for all patients and no need for constant titration. Disadvantage is lack of an antidote and less in terms of controlled studies for specific populations for benefit with dabigatran. The non-pharmacological approaches are based on the premise that we can be as good as Coumadin. We won't prevent all strokes, but the type of stroke that Coumadin prevents probably is the clot in the left atrial appendage, and this can be now removed from the body surgically or the circulation occluded with a device like the endocardially placed devices or epicardial approaches to ligate the appendage as well.
Great. So then I would turn perhaps to both with the question that many patients are sent to us, and with the idea that we would ablate that atrial fibrillation, and therefore that these patients would not need to be on anticoagulation for stroke prevention. So where we are today, and what do you do when you see a patient referred for ablation and with 2 to 3 risk factors for stroke, and how do we consult these patients, Doug?
I think that there are 4 or 5 things that you need to think of if somebody's coming in for an ablation. The first one is their stroke risk. We have to be very clear, though, that ablation is not going to change that stroke risk. The devices that Sam talked about may have a beneficial effect, and surgical intervention might have an effect, but we don't have data to say that an ablative intervention is going to change that stroke risk. And we also don't have data that says that we're going to prevent strokes. It's one of the reasons why we're doing the Cabana trial, is to sort that out. Second thing, tachycardia-induced cardiomyopathy. Some people with really fast heart rates can develop ventricular dysfunction. So that may be something that would push us in the direction of ablative intervention. A third one is morbidity and mortality. Are these people going to die because they have atrial fibrillation? Well, Dr. Asirvatham has already addressed that. Maybe from a stroke, but their fast rate's not going to kill them. And even if we said that they were at higher risk, we need the Cabana trial to say that intervention does anything. Fourth issue that patients bring to us all the time would be, gee, we need to do an ablation early because the atrial fibrillation is going to progress otherwise, and it's going to be all the worse in the future. It's difficult to practice medicine based on something that may or may not happen in the future. You know, you're talking about 20 to 40% of patients with paroxysmal atrial fibrillation that might progress. So when we really get down to the real issue why we ablate, and that's quality of life. And I have to point out that if we have patients with underlying heart disease or congenital heart disease or valvular heart disease, sometimes you don't know. So the first thing that we have to do when we see a new patient is we have to figure out whether the quality of life impairment that they've got is because of Fib. If it is, then an ablative intervention can be a great alternative to long-standing drug therapy. But I think we have to keep all of those issues straight.
Excellent. This is really a natural, I think, point for us to now move from the stroke discussion to where we are with ablative therapy. So Sam, could you comment on how today that when we consult patients for paroxysmal atrial fibrillation and also those patients that with more persistent long-standing atrial fibrillation, where we are with the ablation and the techniques and the results, both the short-term and long-term results, and then also perhaps looking into the future and where we're going with this particular therapeutic option.
So when I'm counseling a patient for AF ablation, I start out by telling them we don't have a cure for atrial fibrillation. And I also emphasize that we're not doing this to save life or prevent stroke, but to control their symptoms and improve their quality of life. And then the discussion changes somewhat based on whether they have paroxysmal or persistent forms of atrial fibrillation. With paroxysmal atrial fibrillation, I explain that it's a trigger that's starting the atrial fibrillation, and ablation today is quite good at identifying and eliminating these triggers, with at least 70% of patients benefiting in terms of improvement in quality of life with a single procedure. On the other hand, with chronic atrial fibrillation, there is probably enough disease in the atrium that ablation alone is best viewed as a palliative type approach along with other methods of treating atrial fibrillation, again with the goal of improving patient quality of life. The future, though, is exciting, I think, we are threshold of appreciating that even with chronic atrial fibrillation, it may be possible with minimal ablation to affect in a more widespread fashion in the atrium the likelihood of it maintaining atrial fibrillation, either because of special areas in the atrium during fibrillation or because of a dysautonomia, an abnormality in the autonomic nervous system that's related in close proximity to the heart.
Great, thank you. And then my question really turned to Doug that we have so many different approaches that to atrial fibrillation and isolation of the pulmonary veins, linear lesion, cafe ablation. And we also have a lot of data from our own experience of long-term outcomes. And so how perhaps in a very concise manner to summarize how do we approach technically to these patients when they come for atrial fibrillation, and what is our data when it comes to longer-term follow-up?
Sure. Dr. Asirvatham has already started on that. You know, again, is this a trigger-dependent arrhythmia or is this a substrate-dependent arrhythmia? You know, what is going on besides the atrial fibrillation? Is there a huge left atrium? So I think the one thing that we have agreed upon, if you look across the country and in fact across the world, is pulmonary vein isolation. You know, using some approach to isolate pulmonary veins and to know in fact that you've done that successfully. You may do that with pacing, you may do that with isoproterenol, or now you may do that with adenosine. So that's where it starts. And then in some patients, as mentioned, then there may be ancillary procedures that should be done. In some cases where there's a lot of underlying disease, an atrial flutter, for example, it may take linear ablation. It may take the ganglion plexus ablation if that is particularly problematic. Rotors is a hot topic right now, and while they may not be rotors per se, they are very focal areas that can be addressed. Now, whether it's a rotor or whether it's a cafe area or just some abnormality of conduction, I'm not sure that that is as important as it is to have some way when you go into the electrophysiology laboratory to be able to identify those areas and to deal with them. In other words, not simply going in to isolate pulmonary veins and then have some empiric procedure that you do in everyone. I think we're becoming a little bit more minimalistic than what we were before. Now, you asked the question about long-term. Here's the problem. Over the last 3 or 4 years, there have been 4 or 5 papers, including one from our own institution, about what happens long-term. Short-term, 70% is a really good number, unless there's a lot of underlying disease. As time goes on, over the course of 5 years, that may drop down to about 30% success rate. So I think one of the keys is understanding that there's a pretty good likelihood that an ablative intervention is going to require repetition at some point. So to get the 70 and the 80% success rates over a long time frame, you really are looking at a couple of different procedures. With paroxysmals, it's less likely to require a second procedure. With other underlying disease, it's more likely to require a second procedure. But the point is, when appropriately done, the procedure or the techniques work very well. And they do provide a great alternative to ongoing antiarrhythmic drug therapy. Patients still need some form of anticoagulation in many cases, and many patients may require an antiarrhythmic drug.
Thank you. Thank you. I'd like to thank both Dr. Packer and Dr. Asirvatham today for this wonderful overview that we touched upon two the major topics related to atrial fibrillation management today. One is on anticoagulation for stroke prevention. We have our traditional warfarin therapy for patients that with high risk for stroke. We also touched upon the new pharmacological arena with dabigatran. And next time we'll be talking more about some of the new drugs that are on the horizon. And Dr. Samuel Asirvatham also reviewed with us about the atrial appendage occlusion process, whether it is occluding the appendage from intravascular, endovascular approach, or through the epicardial approach of ligating the appendage. Dr. Packer reviewed the overall spectrum of atrial fibrillation, and with the epidemics of atrial fibrillation, how do we risk stratify these patients for stroke and the symptoms, and also provide an overview of the ablative therapy for atrial fibrillation. We talked about the various techniques and also the expectations that from patients and also from referring physicians and from ourselves, from the short-term results and to long-term results. So thank you for joining us today, and we look forward to talking to you next time.